Primary healthcare is the most important sector of healthcare anywhere in the world. Unfortunately, in Nigeria, infrastructure gaps, corruption, and lack of political will over the years have led to the deterioration of many primary healthcare centers across the country, putting an undue burden on secondary and tertiary healthcare centers. My guest on the program talks us through a new plan to reinvigorate primary healthcare centers. They are calling it the reimagination of primary healthcare in Nigeria, and it will cost 2.7 trillion naira. Speaking of secondary healthcare, the Garki Hospital is in the news. It's not good news for many, and we will tell you why in our focus on the FCT. And what a week we've had in the presidency. We'll tell you all about it in our Abuja wrap. This is Dateline Abuja. Hello and welcome to Dateline Abuja. I am Kayla Megwa. Let's kick off with a rundown of major stories from Nigeria's presidency.
Following the spate of insecurity in parts of Imo State, President Muhammadu Buhari met with Governor Hope Uzodinma. After the meeting, Governor Uzodinma gave updates on the situation and the arrests that have been made so far.
Well, you recall that a few days ago, the home of the President General of Haneze, Ndibo, was attacked by bandits. And the same night, the police station in Umuguma, Ware West, was also attacked. And for a very long time, if you remember, we've never had such a situation. And this happened at a time that our people already relaxed and thought that insecurity has become a thing of the past. But to the glory of God, security agencies rose to it. The second day, they were properly repelled by security agencies, particularly men of the Directorate of State Service. They've been very useful working with other security agencies. And we didn't also wait. We initiated a community-oriented program where the vigilante approach has been reenacted, and the community leaders have shown sufficient interest, and we'll get there.
The president also met with the chief economic advisor, Professor Doyin Salami, and the Minister of Power, Mr. Abubakar Aliyu. While he shared his concerns over the state of the economy with his economic advisor, he is concerned over the state of electricity in the country.
I directed NAC, MBED, and the Niger Delta Power Holding Company to go into emergency gas contract to ensure that their plants are activated to supply about 800 megawatts from that angle. The Ugweli that was vandalized was repaired and it came back on grid. The gas pipeline was repaired and it came back on grid with around 400 megawatts on grid. So, and a couple of other things that we have agreed to do, and we are chasing them now. They have started yielding results.
President Muhammadu Buhari in Lagos for the commissioning of some projects. While in Lagos, he commissioned the Dangote $2.5 billion fertilizer plants. He also inspected the Lekki Deep Sea Port and then inaugurated the new terminal of the Murtala Mohammed International Airport. He also had audience with President Nana Akufo-Addo of Ghana. Details of the meeting were not made public. President Buhari has cautioned the Economic and Financial Crimes Commission, EFCC, to avoid being used for partisan politics or get dragged into personal disputes. Urging focus on serving the nation to entrench good governance, he issued the admonition while speaking at the unveiling of the Commission's standard operating procedures, policies, and manuals.
I must advise the leadership and operatives of this administration to resist the temptation of being used to partisan politics or be dragged into personal disputes. Your job is to serve the nation in the efforts to entrench good governance. We have ensured the operational independence of the anti-graft agencies, strengthened the legal framework, empowered the regulatory agencies, and provided adequate funding to support the fight against corruption.
The Vice President, Professor Yemi Osinbajo, represented the President at the extraordinary summit of the ECOWAS Authority of Heads of States and Governments. The meeting discussed the political situation in Mali, Guinea, and Burkina Faso. Professor Osinbajo presided over the meeting of the National Economic Council, where state governments were charged to address the gaps that were stalling the 32 transmission projects worth $137 million of investments.
Key expectations from the governors during today's presentation by the coordinator of the Human Capital Development Implementation Program was that the governors are required to actively participate in the national launch of the National Human Capital Development Strategy, which is going to be coming up on the 17th of May, 2022. And also, the governors were also requested to constitute human capital development councils in their state and provide funding support for the coordination of human capital development agenda at the state level. The state governors were also required to express willingness to participate in the human capital development public expenditure and institutional review, which essentially looks at how the public resources, the money of the states is being spent to advance human capital projects. Governors were also asked to continue to express commitment to implement a community-based human capital project in partnership with the several partners, including federal government and other development partners in their states.
The Vice President, in company of his wife, Mrs. Dolapo Osinbajo, attended the 5th anniversary of the Northeast Children's Trust, an initiative aimed at providing education and extensive care support to 10,000 children orphaned by the Boko Haram insurgency.
I think ultimately, service to the people is what our being in government is about. If we're not able to serve the people with everything that we have and with all of our hearts, then really our role is really quite irrelevant and perhaps, unjustified. Even our being there is unjustified.
The Vice President was also at the opening of the National Primary Healthcare Summit, where the government announced a 10-year plan to revamp primary healthcare system in the country at the cost of 2.7 trillion naira.
There is no way that healthcare funding can be paid by government budgets alone. It's simply impossible. The size of the federal government budget itself is so constrained that there is absolutely no way that we can expect to fund healthcare by just budgets. And so healthcare insurance is an important pool of resources for funding healthcare on the scale that will be required for a country of 200 million people or more.
Welcome back. Now let's talk about healthcare. The Garki Hospital is supposed to be a secondary healthcare facility. But my goodness, the place caters to people from all over Abuja with over 34,000 clients, which is much for this 100-bed facility. A concession agreement for the management and operation of the hospital was signed between the Federal Capital Territory Administration and Nisa Premier Hospital 15 years ago. It was a model that was to be replicated across the nation's capital to bring general hospitals across the nation's capital to the best standard possible. Now that contract is over, and the FCT administration has notified the concessionaire of the plan to terminate the agreement. That could mean job losses for over 900 workers at the hospital. Or maybe not. Maybe some arrangement can be reached. But for now, please watch this. Garki Hospital is one of the secondary health facilities in the nation's capital. Almost every district in the Federal Capital Territory has a secondary health facility. This 100-plus bed hospital was initially built to serve residents living within the Garki district. It was renovated in 2001 And in March of 2007, a concession agreement for the management and operation of the newly renovated Garki Hospital was signed between the Federal Capital Territory Administration and Nisa Premier Hospital. The agreement was in line with the federal government's public-private partnership policy, and Nisa was expected to manage the facility under a 15-year concession agreement. Under the agreement, the private provider manages a system where patients get higher quality services. The idea of this public-private partnership model is that it should provide a clear pathway to upgrading the Nigerian healthcare sector to world-best standards. The Infrastructure Concession Regulatory Commission in 2017 indicated the possibility of replicating the initiative to revive more fledgling healthcare centers in Abuja. By the end of this March, the 15-year concession would have expired, and the Federal Capital Territory Administration has notified the concessionaire of the plans to terminate the agreement. However, the House of Representatives wants the administration to stay action on the termination of the agreement pending the outcome of its investigation on the matter.
The short notice of termination of the concession agreement and takeover of the Garki General Hospital by the FCT administration may lead to the displacement of over 3,000 patients with different health conditions. And many highly sensitive, expensive world-class medical equipment may be damaged, as much longer time is needed to be recalibrated before removal and sudden termination notice, which is not in tandem with PPP arrangements according to the Infrastructural Concession Regulatory Commission Act. The House resolved to 1. Urge the Federal Capital Territory Administration, FCTA, to stay action on the termination of the concession agreement on Garki General Hospital, Abuja, pending the intervention of the Committee on Privatization and Commercialization and Health Institutions on the matter. 2. Mandate the Committee on Privatization and Commercialization and Health Institutions to intervene and liaise with the concessionaires, the ICRC, and the FCT administration to resolve the issue for enhanced healthcare delivery in the Federal Capital Territory.
Just about in a month's notice, you gave somebody who has had some developmental plan, he has brought in machines, and the dangers of the patient. Well, we are not actually bothered about the medical officers. They are licensed, they can take employment elsewhere. But what of the patients that are in-house patients that are being monitored? Some of them are under critical condition. The concessionaire is really taking care of them. 3,000 patients, how do you want them to go? So the ICRC Act, as quoted in Section 2.2 and the Guideline 29, have stipulated that.
It's not for us now at this point to stop the process of what they're doing, but to rather investigate. Even if we're able to stop, it's for us to investigate and report back to the House. But that's not what the prayers are saying here. It's that we have gone to conclusion. And I think it is not right as a parliament to take that direction. I'm just not comfortable with the prayers for the motion.
According to figures from the National Health Insurance Scheme, the facility is serving over 34,000 clients. This is to save over 900 workers at the hospital, including 21 consultants, 113 medical doctors, 24 house officers, 159 nurses, 96 patient care attendants, pharmacists, medical record officers, laboratory scientists, and other technicians from losing their jobs.
And even if it's not abrupt.
In a joint media briefing, the FCT chapter of the Nigerian Medical Association and the FCT branch of the Nigerian Bar Association are appealing to the administration to reconsider its stance.
Presently, there are residency postgraduate medical training going on. There are internship going on. Internship, which is even the shortest program, there is 12 months. And someone that started in January, 3 months into the program, you're asking them to pack their bags and go, is not correct. So we need to look at this thing again closely, taking into cognizance the working conditions, those that have been slaving there, their welfare, their emoluments, and all that, even their training, because the training is what even impacts on the standard of the care or the productivity of Garki Hospital.
The parties concerned are keeping tight lips on the matter as the April 1st date draws nearer. Nevertheless, negotiations are still ongoing to determine the status of the agreement. While the Federal Capital Development Authority insists no new memorandum has been tabled before them, the concessionaire is hoping that the negotiations will be favorable. In the meantime, the FCT Hospital Management Board has disowned a post currently trending on social media claiming that it is receiving applications for recruitment into various medical positions, housemanship or internship, including the Garki Hospital. My guest on the program is Dr. Nneka Onwu, the Director of Primary Healthcare Systems Development. Our secondary healthcare facilities are overburdened, and that's because our primary healthcare facilities are largely non-functional. Earlier in the week, we heard of the reimagining of primary healthcare facilities, a 2.7 trillion naira project to be executed over the next 10 years. Dr. Onwu walks us through what this project entails and why this time all this money will not go to waste. Dr. Onwu, welcome to Dateline Abuja.
Thank you very much. It's a pleasure to be here.
Talk to us a bit about primary health care. You know, it's actually pretty worrisome. This is supposed to cater to people at the lowest levels of society. And yet the figures are very worrisome. It actually says 20% of all maternal deaths globally occur in Nigeria.
Yes, definitely.
And it's at those levels.
At all levels.
Well, it's mostly at the rural levels.
Definitely.
So what's the actual problem? Do we not have enough primary health care centers? Do we not have enough personnel? What's the issue?
So we're having challenges within the country. Like you said, 70% of our people are in the rural areas, and the primary health care is the foundation, the first level for all, for care in terms of Nigeria. And the secondary and tertiary are actually referral for more complicated cases. So people are supposed to go to our primary care centers, but they tend to bypass it and go on to the secondary and tertiary, and this is not, acceptable, and that is why we're having these figures. But one would also look at the state of our primary health care.
Yes, because I was just going to say there's a reason why people bypass. Yes. There's a reason why I don't go to the primary health care center in my place. They don't have enough medicine for me. They don't have the kind of treatment and the kind of care. Even at that level, something as simple as malaria.
Definitely.
We still have a lot of that going on in primary health care centers. So people will move to secondary and tertiary.
Yes, so that's what we're talking about, reimagining primary health care, transforming the PHC.
From what to what?
From what we have now to what we want
what
it
is
to
going
be.
on?
So now we're supposed, human resources for health, our health workers, we have inadequate number of health workers in our primary health care centers. We have poor infrastructure. We know commodities, the supply chain, even the capacity where you will store the drugs. Okay, we don't have light. Most of them may not be connected to the grid because of where they are placed. So we're talking about solar. We're talking about, security, making sure that the place is secure and is the environment. There should be water. If you have a primary care center, there should be running water. Many of them don't have running water. So who would want to go there? If you're a woman, would you want to go and deliver where there's no light? Definitely not. You want to go where there's light, because most pregnant, people also deliver late in the night. So we don't have light. The infrastructure is poor in most places. So what the government is talking about now is revitalizing at least 10,000 of them in one, in every ward, at least one in every ward, and that is getting to about 5,000 to 30,000 population. So it's accessible to them, it's close to them, and they're able to go there and see that they have enough midwives running 24-hour service. So I'm talking about a minimum package of care that is defined, and that defines the number of health workers, for midwives and the technical officers, the technicians and the clinical, non-clinical staff. There, of course, the security and the drugs. So what we want is that full package, one PAC per ward, not because of the paint you've put on it. That is not revitalized.
Because I actually wanted to get to that. This is not the first time I am hearing about the revitalizing, reimagining of primary health care centers across the country. Let's not slap paint on a building that is collapsing.
Definitely.
What is the core of the problem with primary health care centers? Because this has been done before. How do we know it won't go back to where it is now?
Have we done it before? No, but we've been building primary care centers all over the country, but we have not been building it in addition, looking at who will be there, where is the human resource, who is the health worker supposed to provide that care to the community, who links them, which is the chief person in the community, to this health worker? Where is the accountability mechanism, which is a ward development committees, and where are the drugs? We had drug revolving fund. Now everything is gone. Now let's look at the budget. 5%, is what is budgeted for health. We know that in some few years back they talked about 15% of a budget for health, but we don't have that. We are struggling with even less than that 5%. So of course, if we don't have that, how can you provide for the people? And that's why we're saying that where we are now is not where we should be. We deserve more as a country. And I know that with the way government is talking about and what we want to do. So when you talk about revitalization, people think it's just slapping paint or like a structure is falling and you put plaster. No. In addition, yes, we want a good structure. You want to walk into a facility that looks nice. That's why people are going to the other ones with funky paints. But you also want to walk in there, somebody cares for them, looks at them with respect. You're pregnant, somebody doesn't talk to you anyhow because there's somebody designated. It's not overworked. The person knows this is her, what she should be doing or he should be doing. And then you go get your drugs, you get consulted. You don't spend the whole day lying around bringing taking tally number because you want to see somebody.
I mean, these are inconveniences.
Yes.
But there's a bigger problem that women die in primary healthcare centers. In fact, there's a talk about it where they say the journey of death to the maternity ward in primary healthcare centers in rural areas.
Yeah, so because people are not attending our primary, some people tend to deliver at home. And we find that a lot of women are delivering at home. And
because they need to use the local women that they have around because the primary healthcare center is not able to keep them healthy.
The primary health care
doesn't have the facility to make sure that this delivery is safe. So you would normally go to that local woman who has been delivering children for women in the community for a very long time, which is risky, yes, but they have to do that because this is insufficient.
And we don't want that. We don't want that. That's why we want to get them back to the primary care center. What is our responsibility to see that, we have a primary health care center that we deserve, one that provides the adequate number of human resources that get paid what they're supposed to be paid, that have the equipment, and that everything is functional, that there is light. If you put somebody in a rural area, she has no house to live in. So we're looking at a primary health care center that has quarters for the doctors, for the nurses. And of course, it goes in line with so many other things. So she feels comfortable to be there and providing the care. And also there's a lab, so she wants to, there's a test you must run or some screening, minor screening. You don't have to go all the way to town, 3 hours or 4 hours, away to get that. Everything is within that structure. That is the primary care level. And it's because if they cannot deal with these things, and 70% of our disease burden can be managed at that level, leaving the other percentage for, referrals and all that. Of course, for referrals, we want ambulances, and that is also part of a reimagining, that we should have ambulances and people responsible to make sure that if there's any emergency, the person is referred to a cluster identified, secondary or tertiary level that knows the person is coming and can, immediately the person leaves, they know the person is coming and they can manage. And then our indices will be better. And of course, we're looking at better budgeting. We have what you call the Basic Healthcare Provision Fund, and being talked about. That is, the 1% of a consolidated revenue fund, additional to what is being provided in the budget. That's 1.5 annually, per ward. And it's inadequate. That is for, getting the nurses, the human resources, the WDC, the meetings, everything, the drugs, the supply, so much, and they cannot just do it on that. So what we are looking at is, taking it up. Even for our insurance, health insurance, we have here, it's 5%. The formal sector, the informal sector, and all those people, vulnerable people, don't have access. We're talking about 90% is what's expected for universal health coverage. But we can't get that if we are still at 5%. So all this discussion will be coming in. How can the private sector support this? We have people who are coming and say, yes, we want to support this. We'll take on the challenge. We take on our local government. We'll adopt that APAs in our local government and see that it's revitalized. In the true sense, means that I have a health worker who is there, and I commit to paying her salary from now till whatever. I commit that the person will have, the right house that I would deserve to live in. And at that primary health care center, I'll be able to send my wife or my child to that health center, because there's light, because the nurses are there, everything is neat, there's clean, there's running water, there are drugs.
All right, well, thank you very much, Dr. Onwu, for being with us on Dateline Abuja, and good luck with the work that you do.
Thank you, and same to you. Do a great job, and it's with you people that we also are able to tell people the right thing to do, where to go to. So I'm sure when people hear this, they know that primary care is not only for the rural women, but for everyone. And we need to work together to strengthen it and revitalize. Thank you. It's been a pleasure.
Thanks to my guest and to everyone who spoke to us today on the program. The reimagining of Nigeria's primary health care is a good thing. But there are questions raised. A 2.7 trillion naira plan backed by the political will of a government that will not be in power in less than a year. How do we know that the next government will continue the plan? Also, it would be a shame to just slap on some paint on moribund primary healthcare buildings and call it revamped. Nigeria has over 30,000 primary healthcare centers, most of which are non-functional, leading to Nigeria's high disease burden and dismal health indicators. That's Dateline Abuja this week. Please let us know the happenings in your neighborhood using the social media handles showing right now on your screen. Thank you so much for watching. I am Kayla Megwa. See you next time.